All right, welcome everyone. Carol, do we need a second or are we okay? I'm sorry, for the public, we're just hang on. We're going to just work out a couple technical issues. Just 2 minutes. Okay, I'm getting the thumbs up, so I think we're good to go. Welcome everyone. Appropriations Committee, our trauma system is something I know that we're all very proud of in the state, second to none in the nation. Last year, we became aware of shortages in some of our dedicated funding to trauma, something we knew we had to fix, and our speaker charged us with trying to fix it. To that end, we established a commission on trauma funding. We want to thank our subcommittee chair, Delegate Shetty, for serving on that and her hard work. And I know our speaker expects us to fix it this year. With that said, we're joined, I think, showing how important this issue is by our Speaker of the House. Madam Speaker, welcome. Any opening comments? I'm going to get right to work, as the speaker usually says. So without further ado, we'll bring up Theodore Delbridge, Executive Director of the Maryland Institute for Emergency Medical Systems, as well as Ben Steffen, Executive Director of the Maryland Health Care Commission, who's going to present the findings from the commission on to study trauma center funding. Welcome.
Good afternoon, Mr. Chair and members of the committee. I'm Dr. Ted Delbridge, Executive Director for MEMS, and I'm going to take the next few minutes, if it's okay, to give you a quick overview of Maryland's trauma system and sort of lay the groundwork for what we're going to talk about. Last year in Maryland, emergency medical services personnel transported more than 558,000 people to Maryland hospitals, having answered more than 1 million calls for help. 25,000 of those people were seriously injured and were taken to hospitals designated in red on this graphic, which hold themselves out as trauma centers. Trauma centers possess special expertise and resources to care for injuries. They invest heavily in readiness, being prepared at all times for the next injured person, and they're designated by MEMS in accordance with COMAR 30.08. Parenthetically, MEMS also designates stroke centers, cardiac interventional centers, and perinatal referral centers. We classify 4 different levels of trauma centers. Level 3 trauma centers I think of as advanced community hospitals that possess sufficient breadth and depth of clinical resources and expertise to manage, sorry for the typo, moderate injuries and initiate stabilizing care. In Maryland, those places are Meritus Medical Center, Tidal Health Peninsula Regional, and UPMC Western Maryland. For trauma patients, they represent the opportunity to stay in communities close to where they live, where the patient lives, and or receive initial life-saving, stabilizing care in preparation for transfer to a more advanced trauma center. Stuck. Sorry. Level 2 trauma centers provide definitive care for a wide range of serious injuries. They are represented in Maryland by Johns Hopkins Bayview Medical Center, Sinai Hospital in Baltimore, Suburban Hospital in Bethesda, and University of Maryland Capital Region Medical Center in Largo. Level 1 trauma centers are capable of providing care for all injuries with an adequate depth of resources and people with serious expertise. And in Maryland, that's the Johns Hopkins Hospital in Baltimore. Parenthetically, Johns Hopkins is the only level 1 pediatric trauma center at the Johns Hopkins Hospital Children's Center. And finally, exclusive to Maryland is the Primary Adult Resource Center, or PARC. It's defined in Maryland statute. It's dedicated to the care of people with serious injury and system leadership. And it is world-renowned as the RM's Cali Shock Trauma Center in Baltimore. And this shows the distribution of trauma centers across the state, the PARC, the level 1 through 3, and the Pediatric Trauma Center. I'll make a special note of Children's National Hospital, which isn't obviously in Maryland, in Washington, D.C., but last year cared for more than 800 injured Maryland children. And this shows the distribution of trauma patients among the trauma centers in Maryland. And as you can see, each trauma center is a valued part of the system. There isn't one that's more important than the other. I thought I'd give a little lay of the land of the spectrum of injuries managed by trauma centers. The purple line at the top represents people injured in motor vehicle incidents. The red line are people injured in firearms incidents, and the green line are people injured in cutting or piercing injuries, sharp injuries. It's interesting that these eventually convey into days spent in the hospital. The purple bar are people injured, cumulative people injured in motor vehicle incidents, but the red bar are people injured from firearms injuries. And you can see that makes a substantial contribution to the total number of hospital days amongst trauma patients. Part of that is due to the average length of stay of those people in the hospital. More than 25% of people injured by firearms injuries spend more than 11 days in the hospital. An outlier when you compare it to people who fall or people injured in motor vehicles. And that is due to higher injury severity. One way of measuring the severity of injuries amongst trauma patients is with a mechanism called the injury severity score. It like any scoring mechanism, has fallacies and shortcomings. Amongst them, in terms of people with gunshot wounds, for example, is a tendency to undervalue the nature of the injury because of the way the score is calculated. It weighs multiple anatomic regions being injured, and gunshot wound victims often are injured only in one anatomic region. Nevertheless, even with that shortcoming, it's in Maryland, it scores people with gunshot wounds as higher than people who fall or people injured in motor vehicle collisions. More than 25% of trauma patients who are there in the trauma center because of firearm-related injury have an ISS score greater than 17, 15 being indicative of major trauma. And as you can see here, people who are injured in firearms injuries by firearms have a higher propensity for mortality. And a final note, people who are injured are oftentimes not having their best day for other reasons. 50% of people who are injured by firearms or pedestrian struck are intoxicated with alcohol or some other substance at the time of their injury. So in 2023, legislation was created to develop the Commission to Study Trauma Center Funding. Its charge was to evaluate changes in staffing, recruitment, compensation, and other factors that would impact the funding needed to operate a trauma center in the state. Recognize changes to approved uses of the Trauma Physician Services Fund over time. Determine the amount of funding needed to fund trauma centers in the state adequately. Evaluate funding mechanisms available to adequately fund trauma centers, and develop funding criteria that would impact the receipt of funds by existing or new trauma centers. And I'll turn it over to Mr. Stefan.
Thank you, Dr. Delbridge, Mr. Chairman, Speaker, subcommittee chairs, ranking members of the committee. My name is Ben Stefan. I'm Executive Director of the Maryland Healthcare Commission. What I want to do is, first off, taking the lead from Dr. Delbridge where he left off, give you a history of the Maryland Trauma Physician Services Fund. If we can advance. Thank you, Dr. Delbridge. Talk a little bit about this. This is a fund that was established in 2003 as a result of the closure of the trauma center in Hagerstown, Maryland. The legislature sprung into action and established a program that reimbursed physicians for uncompensated care losses, raised the reimbursement for Medicaid patients that were being treated for trauma to 100% of Medicare, and established a formula for paying hospitals for what is called on-call cost, which relate to the cost of having a part of the key surgical teams of trauma surgery, anesthesiology, neurosurgery, and orthopedics available and willing to respond within 30 minutes. That formula provides for largely affects level 3s and level 2 facilities. In addition, it directed HSCRC to develop a similar formula for reimbursing trauma centers for what it's called standby expenses, which are costs associated with having physicians at the hospital ready to respond. Interestingly, Historically, standby cost, that is cost of paying physicians to be available and at the hospital, is a cost that can be rolled into hospital rates. On call, which is off-site, is not considered a legitimate hospital or a Part A cost, and therefore has to be funded through other mechanisms. Thus, it was included in the trauma fund framework and has become, up to this point, a key revenue source for trauma centers even today. It's important to note that the legislation in 2003 was viewed as a starting point. It has been reformed several times over the years. The most recent one was in 2018, when for the first time shock trauma was allowed to obtain standby costs, initially through the trauma fund, because it took a year to roll in the cost through the rate setting system, and later through the hospital rate setting system, as it is considered a legitimate Part B cost. If we can go to the next slide, Dr. Delbridge. This slide shows the trends in trauma revenue and trauma expenses. The top line is a total revenue collected. That's obtained through a $250 per year, or $5 per biannual registration and registration renewal for automobiles in Maryland. You can see that the revenue is fairly static across the years. And the three funding streams: on call, the red bar, the red line, uncompensated care, the green, and Medicaid underpayments, the yellow. You can see that as a result of the ACA, really beginning in 2014, insurance coverage expansion meant that uncompensated care burden on the fund dropped sharply as insurance coverage picked up, either through Medicaid or through private coverage. Our expectation is that uncompensated care will continue to trend pretty low. There is a factor to consider in the Medicaid unwinding efforts that are going on, where certain individuals that have over the pandemic qualified for Medicaid coverage may be taken off the rolls, but they could potentially qualify for insurance coverage through the health insurance exchange or directly through private coverage. What is increasing is on call. The trend has been that over the last 2 decades, it's inched up slowly. In part, it's inched up slowly because of added cost. It's also driven by an inflator. We use what is called the Medicare Economic Index physician compensation component inflator to adjust what can be paid through on-call each year. Should note that HSCRC uses a similar inflator to inflate standby costs on an annual basis. Lastly, the yellow line, Medicaid, has not had a significant impact on the fund in the early years, and in later years, we have noted a couple anomalies over the years, but it does show that Medicaid itself is moving toward reimbursing at 100% of Medicare. Keep in mind that the trauma fund only pays the gap between what is paid typically for a Medicaid service and the Medicare 100 rate, and that's a small fractional amount. If we go to the next slide, you can see the picture of the trauma fund. I guess if you want surpluses, if you go to the bottom of the table, you can see that we have significant surpluses over the last several years and projected into 24 under current spending levels. So what's the problem? The reality is that the compensation framework does not align exactly with the revenue that's collected, and more importantly, the need in the trauma fund. The statute, when it was adopted, really was a balancing act among different interests, and the statute is very specific in terms of the formula that are spelled out. The commission and HSCRC, we have no flexibility in increasing the level of payment or increasing the number of hours that trauma centers are qualified to receive under the fund. If we jump to the next slide, Dr. Delbridge, and I'm kind of already trailing what I've said. The statute is very specific. Absent anything else, our recommendation would be that additional flexibility needs to be given to the regulatory agencies in allowing for a more effective and efficient use of the fund, as well as other options that I'll talk about currently. Just to note that on-call payments are based on a statutorily defined formula based on the assumption that each of the level 3 trauma centers would need to be supported for on-call up to 100% of 1 FTE for each of the 4 specialties. Turns out that yields about 35,000 hours a year in on-call coverage, and standby is also allowed up to about 25,000 hours per year in standby expenses. The hours do vary slightly between level 3s, which have more on-call, and level 2s, which have a little bit less on-call, because standby is a requirement in level 2s, unlike level 3s. So if we jump to the next slide, as Dr. Delbridge outlined the charge of the Commission on Trauma Funding, we did put together after the last meeting some design principles we thought were important to think about as we begin to come up with recommendations. The first is to foster effective operation of trauma teams. As Dr. Delbridge has emphasized and other trauma experts have also argued, it's the entire team for trauma care that makes the difference, and having a team ready and able to respond is key to the success of a trauma service in a hospital. It is what we would call the winning formula, but more importantly, it's the survival formula for the patients that are brought in. We also think ensuring equitable access to trauma funding for all the healthcare practitioners, including primarily physicians, but also non-physician healthcare practitioners that also are involved in treating patients, typically in rehab settings after they've been discharged from their initial hospital trauma visit. The third design principle we think is important, and I think I'll get some pushback on this, is trauma center costs should be, first of all, considered, do they qualify as hospital costs, and thus can be incorporated into the hospital rate setting system. As most of you know, we have a very ambitious and visionary hospital rate setting system, but it is not without its challenges, and some of the hospitals have worried with me about this, contending that maybe the framework of the new hospital model is not really as conducive as we need it to be to cover these hospital costs. And lastly, in addition to the motor vehicle assessment, we think it's important that the legislature consider other options for funding this program in addition to the motor vehicle assessments. We're looking at some what the Healthcare Commission would say are sizable increases. Probably you're going to hear not sufficient in the judgment of others, but nonetheless to rely on the trauma assessment today, which is based on MVA registration and registration renewal fees, might be too much for the citizens of Maryland to bear. If we can go to the next slide, please. The key findings, we met 5 times from August to December. We conducted 2 cost surveys. I appreciate the members of the commission, several of whom are with me today in the audience, Dr. Pollack and Dr. Fang. Dr. Fang served as a physician advisor to the commission staff, as well as the head of TraumaNet. But We did conduct cost surveys. We are still digesting that. What I would say about cost in hospitals is you've seen one cost survey from one hospital. You've seen one cost survey from one hospital. The financing is complicated. How hospitals reconcile cost and revenue varies somewhat from across each of the hospitals. And we have a general idea on the direction and the gap, but we can't be quite as specific as we would like. Our key findings are that all trauma centers reported readiness funding was inadequate. Some of it is covered, approximately 50%, but there are significant gaps that the centers themselves are absorbing. As noted previously, uncompensated care, which was one of the key funding challenges in 2003, is not so much anymore. And I would expect as the ACA continues to gather steam that we would see relatively modest compensation through that stream. And although Medicaid is low, we think we want to be more aggressive in pursuing whether MCOs are appropriately paying trauma care. We have had some reports over the years, and we believe that some action, perhaps with using a small bit of money from the trauma fund to reimburse Medicaid for this additional audit of MCOs and their compliance with the trauma rules might be warranted. And lastly, a add-on provision that allowed the Healthcare Commission to award trauma equipment grants needs to be expanded. Under the law, again, very specific, 10% of the funding balance from the previous year can be devoted to trauma equipment grants. That has typically ranged in total for all 9 trauma centers between $250,000 and $600,000. You're not going to buy a lot, and that's for all of them together, not individually. That's not going to buy a lot of medical equipment, you know, for any hospital, but it has been helpful. We think it's appropriate to consider expanding that. If we go to the next slide, we have some recommendations under consideration. We have one additional, perhaps more trauma meetings scheduled, but preliminarily, and I apologize to the commission, there's both those present and listening that they have not had the opportunity to hear all of these. I think they've generally been discussed, but these are in terms of ideas we're thinking of, is to increase on-call and standby cost payments rather. We think basically for both of those, they could potentially be doubled. We also think that the on-call stipends that are paid for the level 2s and level 3s should be aligned with the specialty referral center and pediatric trauma center payments. They have small numbers of hour allotments, but as we increase on-call payments to level 2s and level 3s, we would argue that the pediatric and specialty referral centers would also be similarly reimbursed for their costs. We'd also say that we should give the trauma commission, the Healthcare Commission and HSCRC additional flexibility, enable non-physicians to bill. That's been an issue that has been discussed in the past. As we think about covering the entire trauma team, we think that it is now appropriate to consider that. And we think that it would not be a substantial cost impact to the fund, but would be in terms of equity and transparency, a message to from the legislature that everyone is treated equally. We suggest that HSCRC should more carefully audit the cost information that they collect through their annual rate filing initiatives. They obtain from hospitals what is called a MIMS incremental trauma cost survey. In 2022, hospitals reported about $52 million in additional incremental trauma costs. That was without adding in shock trauma. We think that there may be additional costs that can be reconciled We think that fully capturing those costs is important, even as we would insist that HSCRC needs to have flexibility in implementing the total cost of care model moving forward, but they should include all costs in that reckoning. We also think that there should be an audit process for MCOs. It does not seem as though Medicaid obligations are consistent with the volume of coverage in Maryland. Prior to the unwinding, about 1.6 million Marylanders received coverage from Medicaid. Significant numbers probably received trauma care as well. And lastly, to talk about a hospital that's outside of Maryland, but one that is clearly important to the Maryland trauma system, that is to provide parity with any increases in on-call and standby, as well to the Children's National Hospital, which serves a significant number of Maryland children who are taken there for treatment. We also have a couple of other recommendations that are just simply administrative, but very important. We think it's important. One of the things we realized is that we would be benefited if we could link the trauma registry with the HSCRC hospital discharge data and the MHCC all payer claim data. That would enable us to obtain some answers on the mechanism for injury and track that back into the hospital inpatient and outpatient cost, as well as physician cost, which I know is a key question for some of the legislators. And lastly, as we think about additional funding, I think it's also important to begin to think, not today, but to begin to think about, are there important trauma quality measures that should be used as a consideration for this additional funding. Here we would rely on our partners at MIMS as well as the trauma community in helping us derive what is appropriate. You'll note on that bottom of the slide that we're talking about in terms of these costs, about 9 to 10 million in direct payments from the trauma fund. That includes on-call and payments for the non-physician that we're recommending be included, as well as certain additional expenses for children's, as well as the additional audit cost. In addition, we forecast that about $20 to $25 million could be added in rates by HSCRC. Again, we're not suggesting that they be required to do that. They are accountable for the total cost of care. But we do think that redressing some of these gaps in funding could be accomplished through the rate setting system. In total, our estimate is up to 30 to 35 million in additional funding is needed. I will end here by noting that we have not fully captured the cost at Shock Trauma. I'd note that Shock Trauma is the only trauma hospital in the US. And when we look at that, because over 300 million approximately in cost, kind of swamps the cost of operating community-based trauma centers, we really need to think of whether some of those costs can be funded through other mechanisms rather than trying to blow up the trauma fund to account for what would be a sizable cost that would be reconciled with comparable costs, but at a much fractional level at the community centers going forward. So I conclude my remarks here. Thank you for your patience. And I want to thank my co-director for all the work he's put in, as well as those who are in the room, as well as the elected officials who attended every single trauma meeting. Something of a rarity, but we appreciated your input.
Okay, well, thank you both for the great presentation, and thank you for your service on this commission. Thanks to everyone who served on the commission and your recommendations. Our speaker is headed to Health and Government Operations, but she also wanted to thank you for the work that you've done. Any questions for this panel from the committee? Delegate McCaskill, I see you. Go ahead.
Thank you all. Thank you, Mr. Chair. Thank you all for being here. It's an honor to have you here today. It just literally shows the commitment you have, not just to this presentation, but to the constant care. My question is, the trauma funds only reimburse for the readiness of 4 kinds of providers. So should we be thinking about adding categories, and if so, help us out?
So,
Go ahead, you go first.
so there are under MIMS regulations, and I would qualify this by saying that there have been opportunities where people have taken, I think, unfair swings at the MIMS regulations, because if not for MIMS, there would be the American College of Surgeon standards and requirements that would be in place instead, but they pointed out that over 24 additional specialties have to be available under those regulations. And perhaps the standby being at the hospital and available to respond should be included. We looked at that, and one of the challenges there was we recognized that many of these specialties, while they do provide on-call or standby availability for trauma, they are also at the hospital for other non-trauma services, the bulk of which those services have nothing to do with trauma. So we decided to focus initially on the 4 key specialties first to try to buttress those payments and make a policy shift from thinking that those funds should augment what the hospitals paid to fully or close to fully compensating those 4 specialties, and leaving the rather challenging decision of how to separate out for those other 20 odd specialties when they were on trauma standby and when they were on just routine hospital standby. That's where right now the Trauma Commission is focused currently. Not giving up on that, but recognizing that may be a secondary concern. Dr. Delbridge, I'm sure you have something more to add.
No, I think that characterizes the deliberations of the commission. I think we were mostly interested, the commission as a we were interested in ensuring that we had full funding for the 4 core specialties that represent trauma center. There are requirements for additional surgical subspecialties, and the requirements are different depending on the level of trauma center. It gets a little bit more complicated, and I'm certain that an individual trauma center would advocate for inclusion that's broader. But we wanted to make sure that we at least had this core 4 covered adequately.
Thank you. Thank you, Mr. Chair.
I thank this committee for passing this legislation for this study, and you guys have done an outstanding job. And obviously, rural healthcare is a challenge, not just in Maryland, but across the country. And for us, we have in these trauma situations, we have Trooper 6, Trooper 4, and they were very often deployed. And unfortunately, we're not so organized that we can have these trauma cases where when they come back, we have another one and they can go out and, sometimes it happens at the same time. It happened to me almost 2 years ago when I was in a head-on collision. And Trooper 6 was out. So the only option was to send me down to Salisbury, or at that time, because Kent General wasn't a trauma 3 unit at that time, the other option was to go to Christiana. Fortunately for us on the upper shore, we have Christiana. Mid shore, we're okay because we have Kent General. But the lower shore, at least in Maryland, on the level 3 trauma center is Peninsula right now. Unfortunately, there's a lot of what do they call that? Liquid courage in Ocean City. Too often, folks, if it's between a car and themselves, the car is going to win 100% of the time. And I saw the statistics here. And, if Trooper 4 is out, the only option is to have them go to Salisbury. And I think this is really the premise behind this legislation, to study this. If we don't execute any of these recommendations that you make, can you comment on the sustainability of the trauma center in Salisbury?
I think the leadership from Salisbury, from Tidal Health, would be the best position to answer that question. And I can tell you that they have reached out over the course of the last year or so to express their concerns that they wouldn't be sustainable if there was not additional support that was offered to them.
Yeah. Yeah, I would concur. I think that title has an additional challenge as there is something of a seasonality in the trauma volumes they experience for the reasons Dr. Delbridge outlined to you. I think it is important to note that in this past year, HSCRC did award some additional rate revenue, not specifically for trauma, to title, which I'm sure was somewhat helpful and important to keep in mind.
Thank you. Thank you, Mr. Chair.
Thank you, Chairman. Thank you so much for the work that you have done and so many have done here. For Mr. Steffen, the MGA appropriated 9.5 million in the general fund last year and about almost 12 million. I believe the fund received from the MVA fees. Has that money been spent down? Do you have the flexibility that you need in order to do that? Can you kind of talk about that?
Sure. So we have reached a funding arrangement for the 9.5, which was a one-time funding allotment that was given to hospitals, trauma hospitals, directed at that were in financial need. We concluded that all the trauma hospitals were in some financial need, although the cause for that differed somewhat. So we came up with a formula that took into account the readiness costs that were not supported through reimbursement, the injury severity scores for different hospitals that also should be taken into account, and simply the fact that we had 9 trauma hospitals that deserved some funds. What ended up is that approximately between 900,000 and 1.1 million would be allotted between the eligible trauma centers. We presented that to the trauma centers in early December. I did get a couple favorable comments. We are now briefing executive branch leadership on our plan, but would expect to distribute that 9.5 very shortly. One hurdle, we have to send additionally a notice to the Budget and Appropriations Committees in the legislature to get your concurrence, and at that point we would distribute those funds. The revenue that comes from MVA, as I said, we don't have the flexibility to spend it all, and periodically, because surpluses develop, it does become a target for other legitimate funding needs. In 2018, $8 million was taken from the fund. Again, the commission staff made the point that there were legitimate needs, but they were not permitted under the statute. Their funds were taken in 2018 and returned. Half of that was returned in 2022 when $4 million was reverted back to the fund. Currently, the fund has about a $7 million surplus, not because we can find no needs, but because the statute doesn't permit us a way to distribute it.
So I'm hearing you need the flexibility.
Yeah. Yes.
Thank you so much.
Thank you, Mr. Chair. Thank you both for being here. And I just want to recognize, again, my colleague, my district mate. I've heard a lot about the commission's work over the interim, and I know she's put a tremendous amount of effort into it. We're just really lucky to have her. And thank you again to your team, Dr. Delbridge. I think actually we're working together on a bill, so appreciate you being here. I did just have a question about some of the statistics you showed earlier, particularly around gunshot wound patients. And obviously, when this fund was set up, the world looked very different than 20 years ago than it does today. So I was curious if you can talk a little bit more about the percentage of gunshot wound patients that trauma centers in the state were seeing 20 years ago versus today.
I can't look back. I haven't looked back 20 years. I can tell you over the past 7 years, there has been a bit of an increase. And the increase comes not only in terms of the numbers of gunshot wounds, but in the severity of them.
Thank you. Thank you, Mr. Chair.
Thank you, Mr. Chair. I'm going to ask a question. I don't exactly expect an answer from you, but think about it.
Those are perfect.
My question to you is, I was very surprised to see the high incidence of your patient populations or people that are injured from car accidents. So what I'm interested in is the fact that we have now legalized the use of marijuana. And I guess my concern is I've heard, I don't have the statistics or anything, but the states, particularly Colorado, has seen an increase in problems with their automobile accidents. And I know the surrounding states, Wyoming and the Dakotas, they're not real happy about it. So I was just kind of wondering if you feel that the fact that we have legalized the use of marijuana, that we are going to see a further increase of traffic accidents. And I understand you probably can't answer that question, but I am concerned about it from the experience of other states have had. Now, I know that everybody, depending on which side of the fence you're on, you're going to have different statistics. So, but I am curious about that because that concerns me, because I know it's very interesting watching people drive in snow. They think that they're in a tank and
Maybe
they're
a
just
question
careen
better
down the
for-
road.
For judiciary delegate, but to the extent you have,
Well, I think that's a legitimate concern. I don't think our data yet reflects that. The data that I have access to that flows from the trauma centers lags a little bit. And so won't have time to reflect whether or not that's the case or not. But that might also be an appropriate question for a trauma center leader who's more at the tip of the spear and can give you more contemporaneous answer. But it's something we're paying attention to.
thank you. Subcommittee chair.
Thank you, Mr. Chair. I just want to take a moment to really express gratitude to MHCC for their leadership of the Trauma Commission. This draft report and the presentation is the result of so many hours of incredible work. And I don't take any of it for granted. And I'm very grateful for your partnership on it all along the way. Our subcommittee had an opportunity to do an interim site visit to shock trauma. And I think it was a really excellent opportunity for our members to really see firsthand the important work happening there. And then I separately visited Johns Hopkins Pediatric Burn Center, and really we're so lucky in Maryland to have this system. And it's really wonderful that Madam Speaker has really prioritized fixing this issue. And so I'm grateful for the partnership of MHCC in making that happen. My colleagues asked a lot of really excellent questions, and I just want to ask if you could just briefly, because we're going to be hearing shortly from shock trauma and some of our other level trauma centers, if you can just take a moment and speak broadly as to like how these incredibly important centers that are strategically positioned across the state complement one another.
Why don't you?
Yep. So Maryland benefits extraordinarily from the cooperation amongst these various level trauma centers and the system that they compose. I showed a graphic a while ago that illustrated the distribution of patients amongst all the trauma centers, and how every trauma center participates in the system. It is that systemness that makes Maryland so special. It is the ability to get care when it's possible at a peripheral part of the state at a level 3 trauma center, and have access to world-renowned care at the park if it's necessary, in a transportation system that gets you from where you are to where you need to be. If any one of the trauma centers in our state was to default or excuse itself from participation, it would be tragic. I think that trauma centers themselves can tell you on a day-to-day basis better than I can how those cooperative arrangements materialize or manifest themselves. But I just know that from watching the patients flow from where they are to where they need to be, it's incredibly important, the cooperation that they exemplify with one another.
Delegate Ruff.
Thank you, Mr. Chair. And thank you to both of you and all that you all do for Marylanders. Just think about having visited shock trauma on a couple of occasions and just how difficult those situations are. I wanted to follow up on Delegate Solomon's question about gunshot wound patients, and I wanted to figure out if you guys could give us a broad sense about if you were unaware, I'm a delegate from Baltimore City, so I asked this question to kind of see where the mass of gunshot wound patients are coming from, if it's just Baltimore City, or are there other areas of the state where you are finding there's a mass of gunshot wound patients coming to trauma centers?
I would say, my back of the napkin view perspective is that it certainly is concentrated in the more urban centers of the state, but there is not a part of the state that is immune from firearm related injuries. I see every single day reports of the Maryland State Police Aviation Command and what they've done in the last 12 hours. So I get a report every 12 hours where the helicopters are going and what the nature of the calls were. And I can tell you that they are retrieving gunshot wound patients, firearms related injuries patients from every corner of the state all the time. The propensity, the greatest proportion come to shock trauma. And if in the city of Baltimore, if they're in Baltimore City, another large proportion ends up at Johns Hopkins just because of the geography of where they are. But every trauma center takes care of gunshot, firearm related injuries, and there isn't part of the state that's immune.
I just wanted to add, Delegate Shetty had asked us to estimate the cost of firearms. That turned out to be a bit more challenging than we thought, and it feeds into our recommendation that better integration between the various data systems in the state would be really valuable, because although we have the trauma registry, it doesn't have hospital cost information on it, and to link those two data systems to get a handle on that is really what's the first step. But we're going to work to get that information to the committee. I would also hypothesize, although you don't have evidence yet, that the increasing use of high velocity ammunition, hollow point bullets, probably means that even though weapons injuries have always been with us, the severity over the last decade has probably increased. I'm sure all of you have seen the trajectory of a high velocity bullet, and it doesn't typically run in a straight line once it hits tissue, meaning that more bodily systems are compromised by being injured by these types of weapons. Similar issues are true with hollow point ammunition.
Questions? Thank you both for your work and service to our state in this regard. We're certainly going to be looking at this. I know we're going to have a bill from Delegate Shetty, so stay tuned. Thanks to you both.
Thank you very much.
We're going to hear from our trauma centers. Let's take level 1, 2, and 3 trauma centers together. Zach Arciaga, Jeff Hobbs, Stephen Leonard. You can all come on up, and let's start with Zach Arciaga and go from there.
Thank you, members of the committee and members of the commission. I know this is not an easy topic to address, but one that's really vital and needed. To use a hospital phrase, it's good to have a pulse check every once in a while, maybe not 20 years, but just understand the complexities that trauma centers face. I'm going to focus more of my conversation and dialogue around what it's like to be an adult trauma program manager at Johns Hopkins at downtown. We help coordinate the leadership among the hospitals, both all the services, and the patients that come through to provide timely and comprehensive care for the patients and the families that are affected by trauma. Each of those patients require a rigorous review of performance improvement at multiple levels, and the impact for funding when you look at performance improvement is very clear. From the patient experience perspective, each trauma patient will have a significant impact to their physical and mental health. It'll long outlive their time in the hospital and can affect their societal contributions to care. There's a socio and economic impact to them, whether they can contribute or not to society. The data captured in these programs, both from the work of the trauma program manager and the trauma medical director, really analyze the prevalence of injury within their hospital and locally within the communities that they serve. And it wouldn't be possible without trauma funding support. As a program manager and the focus on patient care and injuries, I just wanted to highlight a couple of things that are concerning. Gunshot wounds, from our perspective at Johns Hopkins Health System, affect the entire state. When you look at the system, suburban, Bayview, JHH, adult, and peds, over 70 zip codes have 2 or more incidents within our system in the last 5 years. Pediatric gun violence has increased significantly over that 5 years span as well. And falls and motor vehicle crashes, as you've seen from the work of MIMS, and aligns with our data as well, that they're prevalent within our system and drive stress. There are parts of ED wait times and contributions that make it difficult to manage other things in addition to the readiness. So when we look to grow our programs and seeing all this data that comes through and trying to figure out how to put systems in place to improve it, we rely heavily on the funding and support structure. 20 years is way too long for a review of Trauma Funding Commission, and appreciate the time that we took having standing dialogue with stakeholders at a legislative level, at the Maryland hospital leadership level, and then the local hospitals as well. We have a unique and creative healthcare reimbursement system that's different from the nation. And so we're going to have to come up with different and creative strategies outside of what the nation does. So through global budgets, we'll rely heavily on those structures to allocate costs, and those structures are going to help us grow. Those are the linkage to data that you guys need to make those impact, and be able to move dynamically and shift through the challenges of a trauma center. If a trauma center wants to go and grow from a level 3 to a level 2, they'll need this funding and support. If they need to get surgeons or other providers into rural areas, they're going to need that funding and support. If they want to benchmark their national performance against other centers in trauma, only 4 of which contribute nationally to trauma quality improvement programs, they're going to need that funding and support through here. And so those dynamic challenges are what I found to be appreciative of the dialogue and discussions from this commission. Those recommendations, I believe, align with ways that we can find new and creative revenue funding for our systems, and to use a hospital, again, another term within the trauma centers, to have continuous quality improvement. Funding is no different and needs to be revisited constantly. There's ever evolving needs with the centers, with patient care, and with new legislative efforts that come out. So we've been appreciative of the shared governance of stakeholders that have come forward with this commission, and appreciate the leadership of Delegate Shetty and the HSCRC and MIMS at the table as well. So thank you.
Good afternoon, Chairperson Barnes, Vice Chair Chang, and distinguished members of the House Appropriations Committee. I am Stephen Leonard, President and CEO of Tidal Health. Thank you for allowing me to address this committee and provide an update on Tidal Health with specific details on trauma care on Maryland's Eastern Shore. I also want to, of course, thank our speaker for her passion and support of this important effort. I would like to express gratitude to the Trauma Commission co-leads who previously spoke, and to the commission members for their dedicated time. I also would want to give a special call out to Senior Vice President and Chief Medical Officer, Dr. Trudy Hall from Tidal Health, who represented level 3 trauma centers with distinction. This commission has tackled a crucial issue, and that is modernizing the trauma fund, one that was developed over 20 years ago, and where the funding and usage have now changed significantly. As the committee is aware, Tidal Health Peninsula Regional stands as the only trauma center on Maryland's Eastern Shore. In trauma care, the golden hour is critical, and the presence of Tidal Health Peninsula Regional is not just a service, it's a lifeline preventing major catastrophes for Marylanders. In 2023, we had the privilege of caring for nearly 2,600 individuals as trauma patients. Our facility is vitally important, especially considering the influx of over 300,000 visitors to our beaches each weekend and 8 million folks annually. Many of these are your constituents seeking leisure, but unfortunately traumas do occur. Of the 2,600 individuals, activated traumas, most trauma cases in our center were from falls at 60%, car accidents at 27%, stabbings 1.6%, and gunshot wounds 1.5% were less common, and as well as burns making up the remainder. I would note that out of our 2,600 patients, about 90% are fully treated at Tidal Health Peninsula Regional. Less than 10% require transfer to a higher level of care. As the Trauma Commission has determined, alternative funding models must be considered, and it's important to align those models with the diverse utilization of a trauma center. Maryland is fortunate to have an exceptional trauma center. We're extremely proud to be an important part of it, but maintaining one of the nation's best systems comes with a substantial cost. Tidal Health Peninsula Regional continues to face funding challenges, albeit better than perhaps when we were here a year ago, considering some of the support we've received. But these challenges are related to mandates requiring additional subspecialties for level 3 trauma centers. And these added costs, unfortunately, fall outside the current scope provided by the HSCRC and the Trauma Fund. It is important to recognize that level 3 trauma requirements exceed level 3 requirements by the American College of Surgery found in other states. I would note that I do also operate a level 3 trauma center in Delaware, and there's a radical difference between our two trauma centers. We even had a surveyor from Boston pretty much describe level 3 in Maryland as a level 1.5 in other states, much more like an academic center. As for recommendations, we support a reassessment and expansion of an on-call and standby funding to support surgical and non-surgical specialties mandated for level 3 programs. The inclusion of other COMAR mandated surgical as well as non-surgical specialties expected for all level 3 programs. And again, this is higher than you'd find elsewhere in the country, but they include OBGYN, thoracic, urology, cardiology, internal medicine, nephrology, neurology, pathology, psychology, and pulmonology. None of those are required for level 3s in other states, but they are required for level 3s in Maryland. Such measures will ensure that our trauma centers are not only compliant with regulations, but also financially sustainable. We have to find a balance that maintains high quality without imposing undue financial strain. But we are ready and willing to help find innovative and sustainable solutions. Second recommendation that I think Mr. Steffen talked about was the existing trauma fund process needs to be revisited. Our recommendation is really an evolution of what is somewhat of a burdensome process, maybe less so with uncompensated care, but still nonetheless it's there. And maybe transitioning to more of a block process that the HSCRC can play an important role. The idea of submitting claims for uncompensated care is really a kind of a bygone way. Lastly, and it hasn't been mentioned thus far, but I feel the need to mention it today. We are the largest employer of physicians on Maryland's Eastern Shore, Tidal Health. I need to point that out because the core issue for trauma services across the state is that of physician reimbursement. Okay. Studies have shown that Maryland now has the distinction of being in the bottom 3 with regards to physician reimbursement. Only Alabama and Delaware have poorer physician reimbursement. This has led to physicians being unable to sustain independent practices. All of our trauma providers were independent 20 years ago, except for one specialty. Now they're all employed. So now folks are ultimately employed by healthcare systems or large venture capital-backed national firms. Let me tell you, they're not much fun to work with. In Maryland, almost all healthcare systems subsidize their employed physicians, and this burden is what is being talked about as being more and more difficult each year. I will tell you, I am looking forward to working with the new HSCRC leadership, MedChi, and hopefully the payers to explore ways we can work together to keep Maryland as a place where high quality services are provided and where Maryland is seen as a destination for physicians, because I can tell you right now it's not. So with that, I want to thank members of the Appropriations Committee for your continued commitment to improving trauma care in Maryland and understanding the subtle differences across the state with regards to rural communities. Your support is crucial in our endeavor to save lives, and we thank you. I'm happy to answer any questions after my colleague completes his remarks.
Good afternoon. My name is Jeffrey Hobbs. I am the Trauma Program Manager at Level 3 Trauma Center, UPMC Western Maryland. What these gentlemen forgot to tell you is they saved the best for last. So here I sit before you today. I'm here today to talk about the Level 3 Trauma Center that we have in Western Maryland and kind of give you a little bit of a picture of our demographics in Western Maryland. We are the little guy when it comes to the Trauma 3 centers. We see the least amount of patients at the trauma centers in Maryland, but that does not make us any less important than the rest of them. As you can see, my next slide here, our trauma numbers are growing. So before COVID, we had about 539 trauma patients entered into the Maryland Trauma Registry. We saw a little dip with the COVID years, but we're making a substantial increase since then, to the tune of 25.9% over last year's volumes that we see in 2023. Everybody's kind of touched on the mechanism of injury today, what causes the injury of our patients. As every Maryland Trauma Center sees, the highest is the fall patients. With a significant amount of elderly folks in our region, we do see a fair number of falls, but then that is followed up by the motor vehicle accidents and then the pedestrians that are struck by vehicles. Penetrating injuries, which penetrating injuries on my graph here includes gunshot wounds, but also knife wounds as well. And then last but not least, a small amount of burns do we see. So why do we need a trauma center in Western Maryland? We are known for our beautiful rural landscape and our remote locations. And because we have that, we also have long distance and transports for patients to hospitals. Not just our hospital, but other hospitals in the region. So that creates, a lengthened amount of time that the person could be in trouble before they reach the care that they need. As you can see here on my slide, the closest trauma center to us is a level 2 trauma center, and it's located in Winchester, Virginia. It's 60 miles from us. The closest level 1 to us is technically Conemaugh Memorial Medical Center in Johnstown, Pennsylvania, 65 miles. But the drive there is a little hairy. So we typically, if we need level 1, the patients go to WVU, Ruby Memorial, Morgantown, which is 75 miles away. That's a great distance, and that's a great amount of transport time, especially when you're talking about ground transportation. The nice thing about our rural area is that we are just that. We are rural. However, we also have poor weather conditions. So the gentleman before us talked about aviation and the availability of helicopters. Yes, we have Trooper 5 in Western Maryland. Its utilization is a lot lower than the rest, in part because the weather conditions. If they can't get off the ground, obviously they can't provide the transports that these patients need. Hence, they come to us by ground. So obviously, we need a trauma center in Western Maryland. They need a trauma center on the Eastern Shore because we're there to save lives. And whenever we're talking about long transports to other trauma centers, we're talking about patients that are dying en route. One of the points that was brought up through the commission's work is talking about funding of the 4 core specialties for trauma care. And we've heard some other folks talk about it today, that level 3 trauma centers are held at a higher level than level 3 trauma centers across the nation. So in Maryland, we require those 4 specialties where it's not required of level 3s in other states. One of those specialties is neurosurgery, and it seems to come under fire a little bit about it. When you talk about where cuts can be made at certain trauma centers, where could you make that cut from your specialties? And neurosurgery seems to come up just a little bit more than the rest. And this slide just talks about why neurosurgery and why any specialty cannot be afforded to be cut from our trauma center. I ran this data because we met with some of our government officials back in December. In the first 10 months of 2023, Western Maryland alone saw 173 patients with some degree of traumatic brain injury. 9 of those patients were taken emergently to the OR for life-saving surgery. Okay, those 9 patients would not have survived the transport from our trauma center to another. Delegate Heimball has heard this story back right after I ran this data. The 10th patient was a 31-year-old gentleman who had fallen after he passed out after getting blood drawn at his family doctor's office, and he hit his head pretty significantly, and he was knocked out cold. He was brought to our center because we're a trauma center, because Maryland EMS knows that we have all the specialties required to take care of the patients that come to us. And when he arrived, we noted that he had a pretty significant epidural bleed, which means it's a bleed above the lining of the brain. Very deadly, deadly within hours. And he was decompensating in front of our eyes. And within the hour, he was in our OR having a life-saving surgery, getting that bleeding stopped and removed from his brain. He would have not survived a trip anywhere else but to Cumberland. So that one life alone, to me, speaks volumes as far as funding is concerned. How much money do you put on somebody's life?
And I too want to thank Delegate Shetty and the subcommittee as well. A lot of folks don't realize the time commitment during the interim that delegates and all of our committees have to take. And this is during a time when you're actually working your other full-time job to pay your bills. And it's not an easy thing to do. And I certainly commend the subcommittee for that. And I just want to follow up with you, Steve, the question I had with the other panel in regards to, I guess, the impact if we don't really.
Yeah,
and I don't think we're not going to do anything. It sounds like we're going to absolutely do something. It'll be a bipartisan effort. It sounds to me, but.
I think for Tidal Health Peninsula Regional, about a year ago, we started raising concerns because we saw three things coming together, which were creating significant financial distress. There was a lot of stuff going on in the post-COVID world with traveler and temp laborers. We have our trauma expense, and we've always struggled with the commission on recognizing trauma expense. And at that point in time, and it continues today, we are one of the highest volume facilities from a growth perspective in the state of Maryland. Put those three things together, and that created really what led to a lot of the conversations that conceptualized this committee in some ways. I'm happy to say in working maybe as a result of those efforts, as a result of, I think, recognition, we remain one of Maryland's most efficient hospitals. So with that efficiency being we're low cost, high quality, we were awarded a little bit less than $38 million, a little bit less than $30 million last year to handle our volume. So one of those issues was addressed by the HSCRC. The labor market's kind of cooled a little bit, which is great. I'm not saying it's easy, but it's taken some of the pressure off. So trauma still continues to be just as much of a challenge as it was before, but taking one or two of those things off the table allows us to continue to engage, continue to make sure we're participating in these important discussions. But I would not characterize it as at risk like we had it being characterized last year. So hopefully that alleviates your concerns. And I must say, Maryland's an awesome system. We're proud to be a part of it. And in many ways, like I said, with all the level threes, there's an important part to play there that literally this was a Harvard surveyor said, you guys are more like 1.5s when it comes to other states. And, people should feel good about going to the mountains. They should feel good about going to the shore. Ultimately, if you have an accident and we're there.
But don't walk out in front of a car though. Either
Yeah,
way.
it's a little better when they put the fence up in Ocean City. That has helped, believe it or not.
Thank you, Mr. Chair, and thank you to all that participated on the commission and to the panel before us today. I also want to say I proudly represent Johns Hopkins Medical Center, just live a few blocks away, but thank you to the whole panel. Two quick questions. One, gunshot patients. I wonder, are they more likely to be readmitted than other patients that face wounds?
I'd have to get you the data to look at that, but that's something.
Just something I'm curious about.
Yeah.
And then my second question is for specialty trauma services like, pediatric burn, do you believe that some of the unique needs for those specialty trauma services, are they properly accounted for in the formula?
I think Mr. Steffen characterized it well. There are certain facilities that provide important services. For instance, we have a relationship with Children's National. They're part of the trauma system. We also sent some patients to the Moores for more of our Delaware presence. So I do think it's important to recognize those specialty centers. Hopkins Bayview for burns, for instance, those are an important part, and they alleviate some of our burdens because we're able to partner with them.
Thank you.
Thank you, Mr. Chair. I just wanted to say first, thank you for your presentation. Members of my subcommittee, Health and Social Services, had an opportunity to do a field trip, an outing to just look at the work that the shock trauma centers across Maryland and just do and have done and continue to do, and I just remain just very impressed with what you all do, given the budget that you all have. And so it's certainly good to hear my colleague Delegate Grice say that this is something that we're going to work on, and sounds like it's going to be a bipartisan effort, and certainly glad to hear. But it was really good to just hear the work that you all do. and really see, from the numbers and to hear from the folks, and I appreciate you all for being here. Thank you, Mr. Chair.
Thank you, Mr. Chair. I'll be brief. This is for Mr. Leonard from Tidal Health, my home hospital. I was out of the hearing room when you were testifying, so maybe you said this in your testimony, but just in case, I just kind of wanted to expound upon the volume that we have at Tidal Health and shock trauma versus, what the perception is of things on the Eastern Shore, with having to deal with Ocean City. So when you're bringing folks into shock trauma or into trauma center at Tidal Health, how many are we treating versus how many we have to send out that we can't treat? Like what's the percentage? Yeah.
Sure. We had 2,600 patients last year. About 91% of them are fully treated at Tidal Health, and about 81 out of the 2,600 went to shock trauma.
Thanks.
To the panelists, we're very lucky in my district to have Suburban Hospital, and we just had a quick question on the number of DUIs that come into shock trauma. Specifically, are they complex? And you spoke a lot about the motor vehicles being a large portion of the kinds of trauma that come in. So if you can touch a little bit into connecting DUIs with sort of the motor vehicles that you see.
I think we would have to get you that data. DUI, we would have to categorize what the language of DUI is in our registries. So that's more maybe of a MIMS discussion of how to get that data to you and use it for an informed decision on things.
Thank you.
Yeah.
Thank you. Thanks, guys.
Thank you.
Testimony as well, Dr. Pollitt, George Sprinkle, and Dr. Scalia, welcome. And for those of you who are matriculating in for bill hearings, we'll get going with those just as soon as we finish up here. So just stay tuned.
Andy, that's Andy's presentation. Just jump me into the right chair. It's okay.
You're right in the middle for the camera.
Right in the middle. Okay. Thank you, Mr. Chairman and committee members. I'm delighted to spend a few minutes with you talking about shock trauma. I will make 3 points. The Shock Trauma Center is the primary adult resource center for trauma in Maryland and the only U.S. trauma center designated above level 1. In other centers, physicians take call for all emergencies, but by state statute, my faculty is dedicated to trauma. The entire building is dedicated to trauma care. This singular focus on the care of badly injured patients allows us to deliver an unequaled level of care. Additionally, in the wake of the Brooklyn mass shootings, the need for mental health and social needs after trauma were highlighted by the governor and legislative leaders. We have unfunded mandates to do violence prevention, trauma education, and research. We are responsible for the totality of trauma care, but this is becoming substantially more problematic. Secondly, organized trauma care requires getting the right person to the right place in the right amount of time. 2,000 times a year, that means transferring patients to us. A third are transferred from other trauma centers. This requires access to beds. Currently, we staff 6 operating rooms when we need 8. We're often unable to complete 4, 5, or 6 cases, which need to be deferred to the next day. This increases length of stay, costs, and makes it harder for us to always have a bed. Efficiency just doesn't get it done every day. And then legislators or families call and say, why has my loved one not been transferred? And we're doing the best we can. I spend hours a day on bed management. Is that how you really want me spending my time? Compared to other trauma centers on the East Coast, our mortality ratio is between 0.6 and 0.7. That means that between 30 and 40% of patients that die elsewhere live if they are cared for at the shock trauma. 30 or 40% of patients that die elsewhere live if they come to the shock trauma center. Last week, I told a story about a young man with a gunshot wound that would be lethal at virtually every trauma center in the U.S. He had immediate access to heroic care, including being placed on cardiopulmonary bypass after surgery. All of this happened in about 90 minutes. And there are many similar stories. This instant access to care simply doesn't exist anyplace else. I hope we're not, he lived, and I hope we're not going to be willing to let those people die now. How good a trauma system do we want? We want the absolute best, and a strong shock trauma center is the core of that system. If I have to tell a mother her son or daughter is never coming home again, I have to know that that kid had every possible chance. It's what you would want. It's what Marylanders deserve. Thirdly, injuries becoming more complicated. We see approximately 1,000 victims of interpersonal violence a year, far and away the largest in the state of Maryland. The complexity of taking care of a patient with 3 gunshot wounds is actually more complicated than taking care of 3 patients who have been shot once. The competing priorities of multicavitary injuries in the same patient requires rapid and sophisticated judgment, and these are becoming more common. A recent review of the trends in homicide victims in Maryland showed that the proportion of firearm victims with greater than 10 gunshot wounds nearly doubled. Patients with 5 or more stabbings increased from 39 to 50%, and assault victims with 5 or more fractures increased from 20 to 38%. Complicated patients take a lot of resources to provide care for. For 50 years, Marylanders have had the best trauma system in the world, but that system is being sorely stressed. We need a funding system for the future, not one rooted in the past. Using the same mechanism to patch a budgetary hole will not do it. This is our future. There can be no going back. The costs are high, but the costs we're talking about for shock trauma represent under 1/1000th of the state budget. And this is going to save lives. We've only ever asked for the resources to do our job. And that's what we're asking for now. For 50 years, the legislature has always voted to support trauma care. We stay in the trauma system because we believe. We want you to once again believe too. How good a trauma center do we need? I think you know the answer to the question. Thank you for your time and consideration.
Mr. Chairman, members of the committee, thanks for the opportunity to testify. My name is Dr. Andy Pollack, and I have the privilege of serving as the Chief Clinical Officer for the University of Maryland Medical System. I want to add my thanks to Mr. Steffen and Dr. Delbridge and Subcommittee Chair Shetty for their work on the Trauma Commission, on which I had the privilege of serving as well. For the past 30 years, my clinical job has been as an orthopedic traumatologist working at the R. Adams Cowley Shock Trauma Center alongside Dr. Scalea. You would have thought that by now I would have learned not to follow him, but apparently not. You just heard Dr. Scalea describe the why of our trauma system. Now I'd like to give you an idea of the how much. Specifically, how much does it cost to get those results? First and foremost, when we look at the past 5 years, we've faced unprecedented financial challenges related to inflation in the cost of dedicated staff, the cost of supplies, drugs, and purchase services. While the HSCRC provides support in the rate structure for most of the cost of the care that we deliver, the unfunded portion is growing substantially. On the hospital side, the unfunded portion of the cost of inflation of salaries, supplies, drugs, and services since 2018 is almost $18 million. In addition to that, despite substantial support from the hospital and net of the support already received from the trauma fund as it exists today, our faculty practice plans are operating at a deficit of $6.3 million, resulting in a total program stabilization amount of approximately $24 million annually. Dr. Scalea talked about the need to run more operating rooms in order to be able to reliably provide the care to the citizens of Maryland that we're expected to provide. In order to grow to the capacity to staff 8 of the 9 physical operating rooms that exist, both in terms of the nursing costs, anesthesia, supply, and surgeon costs,
we need to invest another $15 million a year. We should be investing more in prevention so that in the future, the rate of injury to the population eventually decreases. We also need to invest more in our quality and education programs. None of that's currently funded through the trauma rates or through support in the trauma fund. That's another $10 million in annual cost. Thus, the total incremental annual funding support necessary for shock trauma alone is approximately $49 million a year. With regard specifically to the program stabilization request of $24 million annually, it's fair to ask where'd that number come from? Well, as the slide shows, the increase in funding since FY18 through the HSCRC rate setting system has been on the order of 18%. There's been no increase in the support received from the EMS operating fund and minimal increase in the standby funds we received from the Trauma Physician Services Fund. On top of that, there's been a frank decrease in the revenue the faculty practice plan receives from billing and collecting. Simultaneously, we've seen significant increases in overall costs. Expense inflation for staff, including nurses, technicians, therapists, pharmacy, and others, all of whom remain relatively underpaid compared to the market, has been almost 30% since 2018. At the Shock Trauma Center alone, staff salary costs have increased by $22 million in that time. Drug costs in FY23 were almost 10% higher than prior year. Faculty salaries remain behind market, making recruitment and retention difficult, despite salary cost inflation of 11%. Financial challenges at Capital Region Medical Center in Prince George's County have been no less daunting. While the comparison is not apples to apples because Shock Trauma is a purely dedicated trauma facility, and Capital Region is able to offset some of its standby trauma costs by layering them on top of a full service medical center, the support that Capital Region receives through the rate setting system and the trauma fund is inadequate to offset the pure trauma costs incurred. Total unrecoverable costs associated with excess uncompensated care, on-call payments, standby support, and physician services agreements to specialists, support for the cadre of physician's assistants necessary to deliver care, and the administrative costs of running the trauma center total $18.6 million. That's partially offset by $3.5 million in support from the trauma fund, but the shortfall is $15 million. These shortfalls are significant, and without substantial continued support, both the ability of our trauma system to continue to meet the needs of our citizens and to improve access to care for the most vulnerable among us will be in jeopardy. Thank you.
Thanks for your testimony and being with us. And Dr. Scalia, a special thank you to you. Your work in trauma is legendary. We're so happy to have retained you the last 25 years in the state of Maryland. I think it's a testament to how strong our trauma system is. We need to keep it with strength, and really to all of our doctors, nurses, and healthcare professionals at our trauma center on behalf of the committee.
We're not going anywhere.
Thank you for the great work. Thank you for that. Delegate Shetty.
To my colleague.
Yes.
Delegate.
Thank you, Mr. Chair, and I strongly echo your comments. Thank you for saving lives. We appreciate you so much. As you alluded to, the shock trauma is not funded the same way as the rest of the trauma system in Maryland. Can you talk about that more specifically and how MEMSOF plays a role in the funding and the shortfalls that you're talking about right now?
Andy, you want to?
Yeah, so all of our hospitals in Maryland receive funding, receive rates from the HSCRC, from the Health Services Cost Review Commission. In most trauma centers in Maryland and throughout the entire country, the standby costs and the excess costs of delivering trauma care are distributed across a base of a large medical center. In other words, you can take physical therapists, operating room nurses, recovery room nurses, and use them to take care of not just trauma patients, but other patients. It distributes the cost across things. It allows you to distribute the cost across service lines like orthopedics and cardiac surgery that have very predictable volumes. Patients come in for elective surgery, you know how many they're going to be every day, and there's some variability layered on top of it, but you're not subject to the pure variability of trauma, which goes up and down. At the Shock Trauma Center, we have a state mandate to serve as a pure trauma hospital. It's attached to the medical center, but our trauma operating rooms aren't shared. Our trauma recovery rooms not shared. We have a trauma ICU, trauma neuro ICU that's not shared, a multi-trauma ICU that's not shared. All of that represents incremental cost. It increases our ability to take care of patients. It increases our ability to respond in a timely fashion. It's why Dr. Scalia said you're 30 to 40% difference in the survival rate relative to other similar trauma centers. It's a resource that other states don't have, but it costs more. And that's what you see here. Overall, the amount of additional support relative to other states, I would say, is marginal. We're doing a good job with what we have of spending money wisely, but it is expensive. Okay, thank you.
We've got 2 more questions.
Thank you, Mr. Chair, and I want to echo the words for our delegate Shelley for doing such a tremendous work. Dr. Scalia, 10 years ago when I came into the House, former Speaker Michael Bush, when we doing our freshman tour, he said some words that really stuck out to me and said, we must and we will need to take care of shock trauma the best way we can. And I truly want you to know that at 3 o'clock in the morning, when I see you out at a press conference, it speaks to the volume and the heart that you have for what you do, and not just for you, but for the trauma center itself and your staff. And I just felt like I wanted to share and just tell you that there's people that are on your side. God bless you.
Well, that's very kind of you. And thank you. I got to tell you, I've got the best job in the United States. I do. And it's the only job I would have left New York City to take. And I am so happy that I got the chance to do it.
The galas that you have and the Stop the Bleed has really resonated with people of Maryland, because I think they're taking those tests. Thank you.
My colleague Delegate Ruff asked a question about the role that MEMSOF plays in funding shock trauma. And so I know over the years, the percentage of the MEMSOF budget has really shifted, and shock trauma receives around, please correct me if I'm wrong, maybe 3% of the total, 3 to 4% of the MEMSOF fund. Can you talk a little bit about how that has shifted over the years, and maybe to the extent that you're able, what else MEMSOF funds?
The specific funding for MEMSOF is probably best answered by Dr. Delbridge. I would say, I don't know, put him on the spot, but if you want to. The total amount that shock trauma receives from the MEMSOF has not changed, but how the total fund is split up.
MEMSOF, the Maryland Emergency Medical Services Operation Fund funds 80% of the Maryland State Police Aviation Command expense. It funds the entirety of the operating budget for MEMS, the Maryland Institute for Emergency Medical Services Systems. It funds nearly the entire operating budget for the Maryland Fire Rescue Institute, which provides firefighter and EMS clinician education. It funds $15 million for what are known as AMIS grants, basically capital improvement grants for public safety for EMS and fire, distributed to counties based on property tax revenue. And it funds $3.7 million to the R. Adams Cali Shock Trauma Center. The $15 million number hasn't changed in a really, really long time. The $3.7 million to the R. Adams Cali Shock Trauma Center has been that way for a number of years. The only variability are the expenses related to MEMS, MIFRI, and the Maryland State Police Aviation Command, which increases, inflation increases.
Okay, thank
so
you.
in terms of a proportion, I'm sure it has decreased, but in terms of its absolute value, it stayed the same for a long time.
I believe the proportion was about 10%.
10% at the beginning, now
4%.
Now 4%.
Understood. Okay, thank you. I just want to point out, I think it's really important to note, and thank you, Dr. Delbridge, for coming back and sharing this answer. I should have asked while you were on the panel, but I'm grateful for the information. I think it's important to note that shock trauma's needs have increased significantly as shared by our presenters. And it might be worth reviewing some of the current things that are funded through MEMSOF and whether it might be appropriate to consider funding it through other parts of the budget. So thank you, Mr. Chair. Really appreciate it. Thank you, presenters.
For all your work. To all our presenters here today, thank you so much for the work you've done, for your presentation. I know that this is a continued discussion as we move through session, and this committee is going to work on these issues. So with that, thank you so much. Committee, we are going to take a 5-minute break so we can get set up for our bill hearings. So let's say 2:35, we'll be back here. Thank you all.